Sure.
I think that you'll just have to re-screen share because we screen shared our slide. So we should be good to go, inshallah. Okay.
So I have to re-screen share, sorry?
Yes.
Okay, let me see. Continue.
Good morning, everyone. Welcome to TeleShadowing. We're live on YouTube. Please feel free to ask questions in the chat box as we go along and they will be addressed. I'm honored to introduce our mentor for today, Dr. Khurram. Dr. Khurram serves as the clinical assistant professor at the Sam Houston University School of Osteopathic Medicine and is also a pathologist affiliated with the HCA Houston Healthcare System. Dr. Khurram is also the founding president of PAPS, which stands for the Pakistani American Pathology Society, which is a nonprofit organization established to serve as a platform to enhance the educational and professional development of Pakistanis interested in pursuing mentorship opportunities with pathologists trained in the United States. And now it is my honor to request Dr. Khurram to begin today's session. Thank you.
Thank you very much, Manahil. So nice of you. And I'm really appreciative of TeleShadowing.com to arrange these wonderful webinars and virtual electives. This was very much needed. And I know this is how you guys started probably back in COVID. So you came up with this great idea and it's working out great. So thank you for, letting me speak to this panel. So good morning, everyone, or good evening, wherever you are in the world. It's good to be to have you all here. So basically, as you might have seen, most of you would have already attended these, what we are calling the virtual electives. It's just about an hour of talk, and then this is going to be followed by question and answers and quiz and all. We've covered a few broad topics, and today I'm going to cover just a brief introduction of gastrointestinal pathology. And I mean, GI pathology, of course, it's huge. I mean, it cannot be covered in 1 hour at all. It's not even close. But what I'm trying to do is just to give you a brief idea, just to give you just the background of histology first, and then we'll go through some of the common pathologies that I usually see. And not only me, it's just that this is just the common practice. No matter wherever you go, if you're going to see GI pathology, these are the things that you're going to see every day. But before that, I also do a brief kind of an overview of pathology practice in general in the US. So just a little bit about myself. I know most of you who work with me I've been mentoring. You know that I'm passionate about mentoring and helping younger colleagues and whatever I can. Like Manahil mentioned, I'm the founding president of PAPS, and there's another organization kind of similar what I started, and I'm founding member of that also. And then this current TeleShadowing network, I'm a regional medical director of this network also. Then I'm also actively involved with APNA, Young Physician Committee, and my own alumni, which is Liaquat. And then there's some couple of other mentorship programs that I am very passionate, and this is just a few things that I've been doing, just put it on the slide. So like I said, there are going to be two very brief. First part of the my talk would be about the practice of pathology in the US. So you guys, most of you may not be aware of what it is like, what is the training structure like, what are the career option, what is the business side of the labs, and what is the future outlook. So this is going to be very brief, like maybe 5 minutes, but most of the parts, most of my talk would be about the GI pathology. I must say that this all the material that I'm going to be presenting, the first part, the practice of pathology, is being contributed by a very good friend of mine, Dr. Adil Ahmed, who's a derm path. And then the second part, the actual GI pathology, is contributed by two of my students, very bright students, Dr. Amama Burgari and Suzanne Chandraganti. So these are contributed by them. So let's get started. Pathology training structure. There are mainly, the most common one is the combined anatomic and clinical pathology. This is going to be a 4-year program, and then some programs do have like a split, just anatomic or just clinical pathology also. But those are not the famous one, because once you are in practice, most of the groups or the employers would kind of require a combined APCP training. And once you go through any of these route, anatomic or clinical pathology, you have kind of these subspecialty boards. You name it, we have it. We have every single subspecialty you can think of. The first few includes among the surgical pathology or anatomic pathology. The last, like microbiology, clinical chemistry, transfusion, they come under the clinical pathology. The combined APCP is a 4-year training, And then if you do AP or CP alone, this is going to be a 3-year training. That approximately there are about 600 first PGY1 position, CGMA accredited positions in this country, and then about, I think, 150 total residency program in the country. Number of practicing pathologists, this is somewhat older data in the country, is about 12,000. I think this went up to about 16,000 in 2017, but this also went down from 2017 onwards. It went pretty down because of large number of retirements. To the extent that the job market of pathologists currently is the best that we have ever seen. There has been within the American graduates, for some reason, there has been a severe decline from the MDs. I'm talking about there was a data published back in from 27 to 2017. There was a 17% decline, but recently I was at one of the meeting of CAP, and then they mentioned there has been about 35 or somewhere in that range, more than 30% decline within the American graduates. But at the same time, this has been picking up for last 2 years and has gone up a little bit. And this is being increasingly famous among the DOs. And if most of the attendees today are IMGs, there has been a severe, I guess in some countries, I would say from Pakistan, there has been about 200 to 250% increase in the applicants for last couple of years that we've seen. So it's become very competitive, although not from the American graduates point of view, but from the IMG's point of view, it is becoming very competitive. What are the post-training career path? Now, this is again important when you go into your interviews and talk about it, because I remember last year one of my mentees, when he was interviewing, and he mentioned something weird that it just made like during the interview, the people, they did not know what is the post-training career paths like. So most of the model these days is like, you're going to be hospital employed. So whenever in the US, you have seen most of the practice is community-based practice, means hospital-based but community practice. Then there are 2 routes with that. You can be employed by the hospital, or you can have your own group kind of contracted with the hospital. Then there are some independently owned outpatient reference lab. There's this multi-specialty and single specialty groups. Then there's, of course, academic medical center, and then the corporate. There's also some hybrid kind of models with research, especially in academics. Then the other growing industries, biotech and biopharma industries, is also related to pathology. But just an overall snapshot of the laboratory industry in the US is approximately 80 billion cap, and then the biggest players are the Quest, LabCorp. They kind of do pretty much all the stuff, AP, CP, molecular, and all that. But then there's Sonic, Path Group, and all that they are more surgical and anatomic pathology. HCA is becoming very big, and then the other group is Inform. Just a few big names I'm mentioning. And there's kind of widespread consolidation in the marketplace. Also, the volume are increasing, and the need of experienced pathologists has been greatest. And like I said, the job market has been pretty good. This slide, I think this is for you guys. Maybe this is just too early, but I always tell my mentees it's also important to kind of know what we are talking about when you go out and practice. So money, it's very important to kind of understand. I mean, this should not change your decision if you want to be a pathologist or not, but just to kind of understand. So hospital-based employment can range from somewhere around 200 to 400K annually. This also depends, of course, based on location, your subspecialty, your experience. The academics are always lower. I mean, 120 is pretty low, but if you're like junior faculty, you may start from 120, but this is kind of pretty low. So average is about 180, 200, and then academics can go up to 350 in some areas. Some of the niche specialties, like very high volume derm path, the potential of earning is very, very high. So that's kind of an overall in academics. There is this consult service, and this is where the some of the revenue comes from, and some very busy consult services known to get like even $2 million a year. So, but this is again rare. The average you should think about between 200 to 400. Future outlook for pathology is great. I believe it's very bright. Molecular pathology is growing very fast, and so is AI and informatics. But there's always demand for subspecialty training. So I think still the future is very bright. So moving on to my next part. Now, this is a kind of a bigger presentation, so I'll try to see, I mean, we'll have to try to stay in this 1 hour, but my first part is going to be focused on the upper GI. And as you might know, upper GI, we start from the esophagus and go all the way to the GE junction. So esophagus, I mean, again, my audience is kind of mix and match of physicians who have graduated, and some of them may be in practice, and then now looking for pathology residency. Then I have college students, I have medical students. So it's kind of hard to work on this presentation and see. So I've tried my best to kind of include the very basic and some of the very common things. So esophagus, as you would all know, of course, is just a muscular tube about 25 centimeter in length, and this begins at about cricoid and ends at about GE junction. So we're not going to go into the function, but today I will just focus on the histology part. And I know there are some of the students today who are going to be starting their residency. So it's important for them to just understand kind of what the basic anatomy or the basic histology of the esophagus is. So any luminal or tubular GI that we say, tubular GI meaning all the tubular structures like the esophagus and intestine and all that, will have mucosa. You'll have the submucosa, the musculus propria, and the adventitia. And then mucosa is the main the thing that will be different in every other structure that you go on. So for example, esophagus, I'm surprised in many times that many of the students who rotated, I mean, of course, pathology is not the integral part of the syllabus. Like, it's not a mandatory rotation anywhere in the world. I've seen, like, I have students from Pakistan, I have students from US, from Caribbean, from Philippines, from Vietnam, and all over. And most of those places, pathology or histology is just there, but it's not, I think, mandatory. So many people may not know. And so I get surprised many times that when students or graduates or medical graduates who have graduated, they even would not know what is the epithelium. What do we mean by epithelium? What is mucosa? What is a mucosa? What is musculus propria, serosa, and all that? So that's why I try to just put it, just the basic. Esophagus is lined by here, as you can see. This is the stratified squamous epithelium. Pretty much the entire esophagus is lined by stratified squamous epithelium, and right at the GE junction, this will kind of change into the columnar epithelium. The mucosa will involve the epithelium and the lamina propria. The submucosa is mostly the blood vessels, the minus plexus, and all that. And then we have the muscularis propria and a little bit of serosa. The muscularis propria, of course, it changes depending on which organ system are we talking about. Just a little bit of higher picture again of the GE junction. Again, here you can see this is the stratified squamous epithelium. Right? I mean, at the base, you will see it's more blue, or basal would be kind of more blue because that's where it's proliferating. And then there's a surface maturation, meaning as the epithelium goes toward the surface, they mature, they will have more cytoplasm, they'll become more pink than blue. And so this is kind of normal. But when you see if the entire epithelium, entire thickness is blue, then that's where you would be worried about if there's something going on, if it's dysplastic or not. And then right here, the GE junction, where we start the stomach, and it becomes all this columnar or foveolar kind of epithelium here. And then this is the lamina propria, just the basic histology. Moving on to the common pathologies of the esophagus. The most common, of course, in this country, I think pretty much all over, is the reflux disease. This is going to be the most common presentation. The patient will come up with GERD kind of symptoms, and this is basically due to the disruption of the normal GE junction. Histologic features, what we see every day on the slides, would be mild. Again, these terms you may not be very familiar with these terms, but I mean, as a pathology student, as an incoming PGY1, or as rotating into pathology, these are literally the most basic things that you would need to know. And I would say, if not in majority, a good proportion of people, students, they in fact, they do not know about all this. So mild basal cell hyperplasia, and again, if we go back and we are talking about, okay, so we went forward. So this is basically what I mean by mild basal. So you see these blue at the base. This is the surface again, here, and this is the base. So the basal cell will become more hyperplastic, or more kind of, you see more, there's more dark hyperchromatic kind of cells here. And then the other feature is this, what we call the elongation of stromal papillae. So this is normal papillae, right? Sorry, abnormal is this, as you can see, this is kind of going all the way to the surface. This is kind of involving the 2/3 of the entire thickness of this mucosa. So this is one of the other features. The third thing is that you may also see some intraepithelial lymphocytes and eosinophils. Again, very important point is that you may see some eosinophils in reflux esophagitis. Um, and the other common thing that we'll discuss is the eosinophilic esophagitis and how do we differentiate between the two. But basically, look at just this picture. You see something like this, basilar hyperplasia, elongation of the stromal papillae, and increase in intracellular eosinophils or lymphocytes. You would think about the reflux esophagitis. Um, and then moving on, the other is, like I said, the other differential of the of reflux esophagitis would be the eosinophilic esophagitis. Eosinophilic esophagitis or the allergic esophagitis is basically it's a chronic immune antigen-mediated esophageal disease. And then the features here we are talking about, mostly we're talking about there's going to be increase in intraepithelial eosinophils. Now we're not talking about the eosinophils in the lamina propria, only in the epithelium. Some of the other features we will see there's going to be some marked basal cell hyperplasia, eosinophilic microabscesses, full thickness of epithelial eosinophilic distribution, and lamina propria fibrosis. There's also going to be some eosinophilic dysgranulation. So here, this is what we are talking about, some basal cell hyperplasia. Again, something similar to what we saw in the reflux esophagitis, okay? But there's, as you can see, there's no elongation of the papillae, right? Just to, again, I'm going very basic. What do we mean by papillae? That you'll see some fibrovascular core here around. It's kind of becoming like a papillae. You do not see any of that here, right? If you compare this with the reflux esophagitis, again, this basal zone hyperplasia is there, but it's not like what we saw in the reflux esophagitis. This lamina propria fibrosis is very mild and can be ignored. I mean, this is not a very salient features. But the other thing is, like, you can see these here kind of at the towards the surface is going to be eosinophilic abscesses, or what we call microabscess. And then you can also see some eosinophilic surface layering. But basically, bottom line is you will see tons of eosinophils. On this power, I think you may not be able to see, but these pink bilobed cells and with have these granular kind of pink cytoplasm, those are the eosinophils, which I can see in this picture. I'm sure most of you may not be able to catch that, but there's tons of eosinophils in this intraepithelial. The magic number is 15. If you see more than 15 eosinophils in single high power field, we are talking about, most of you'd have used microscope, and when you go on, the 40x is what we are calling a single high power field. So in that high power field, if you see 15, more than 15, that's where you kind of would think about eosinophilic esophagitis. Now, of course, there's no 100%. So there, if you see some features that you have elongation of papillae, you have basal cell kind of hyperplasia, along with it, you have about, let's say, 17 eosinophils. Would you call it eosinophilic esophagitis? So in those cases, I generally put a differential diagnosis, and I mention my findings, what I'm looking at, and I put that in, and then I put a comment in my report that this is what I see. So this can be reflux esophagitis, or this can be eosinophilic esophagitis. So it's just clinical correlation is recommended. So of course they would go, the clinician would kind of see around how the patient is presenting and all that, and based on the clinical findings, they can kind of pick and choose that, okay, this looks more of reflux esophagitis, or this looks more of like eosinophilic esophagitis. The other common thing that we see in eosinophilic esophagitis on the endoscopy, I forgot to mention that, but this is kind of the buzzword that you'll see the Feline ridges, or you'll have kind of the ridges at the when they go endoscopically, and they'll see those kind of ridges in the esophagus. So that's kind of the buzzword. Moving on, the next most common thing is the Barrett's esophagus, and whenever we get the GE junction biopsy, there is always one thing that rule out Barrett's esophagus. So Barrett's esophagus, of course, is a complication of GERD, reflux disease, but this is one of the most important thing in the upper GI that we must have to mention. that if there's any metaplasia or not. Why? Because this is pre-malignant. So intestinal metaplasia, it must be mentioned. And whenever there's intestinal metaplasia, we always kind of look for if there's any dysplasia or not. So we always kind of mention that also in the report. Now, most of you who would work with me, I'll see that I do not usually put the negatives, all the negatives in my report, but the pertinent negatives in this case, when there's no dysplasia, I would mention it, there's no dysplasia. It just kind of gives the clinician a kind of an reassurance that yes, I did look for a dysplasia. Not that if there's dysplasia, I would not mention it in my report, I would of course mention it, but they also would like to see those pertinent negatives in the report. So what you see here, again, this is the squamocolumnar junctional mucosa. Here on the right, you can see this is squamous mucosa. Right here at the G junction, you have the columnar mucosa, which is stomach, right? This is foveolar type epithelium. So many people think that just the squamous becoming columnar is the Barrett's. No, this is normal, right? At G junction, the squamous will kind of right at the junction where it becomes the stomach, it's going to be columnar mucosa. But when you see these kind of goblet cells scattered around, you see these blobs, white mucinous looking cells, goblet cells in the columnar epithelium, this is where you would call Barrett's esophagus. And Barrett's esophagus, again, is a combined histologic and clinical diagnosis. So for example, on endoscopically, they will see some salmon colored mucosa. And then if we see the intestinal metaplasia, then combined, then that this is Barrett's esophagus. So again, very important thing to mention in the report, that if you have the dysplasia or not. Moving on to the stomach, I'm thinking, it's going to be hard for you guys to kind of go back. And now, if you have any questions about the esophagus, maybe I can answer it now, or we can just move forward because I have a lot to cover. So maybe just keep notes if you want to ask about something, keep notes of it, and then we can go at the end. So moving along to the stomach. Again, I'm sure you all would know this is a cyclic J-shaped organ, but it's important to kind of know where it starts, like right at the cardia. Many times we'll see the biopsy, it's labeled as distal esophagus, but all we have is the squamous type epithelium. So maybe they went too far, and they right there, they kind of got the samples from the cardia and not from the esophagus. So that's something. Then the fundus and body are kind of lined by different, little bit of different type of epithelium, right? At the pylorus, where it becomes the duodenum, again, you may be able to see some duodenal mucosa and not the stomach mucosa, right? So moving on, the microscopic anatomy of the stomach. Again, every tube is lined by the mucosa, the submucosa, musculus propria. The difference here in musculus propria of the stomach is that this will have a 3-layer. Again, histologically, it doesn't really matter, but just so that you guys know, this is like 3 layers of muscle as compared to 2 layers of muscle in the esophagus. The mucosa has got some superficial pits, or what we call the foveolar type epithelium, and then the deep glands also. Then we have the cardia, and the antral glands are more mucinous. So again, this is kind of important. You have some company. I think it has never happened to me that I'm giving a talk that my girls will not show up. They always show up. So sorry about the infusion. So moving on, the mucosa is kind of in the body and fundus, it contains the specialized chief and parietal cells. So when the biopsy is from the body and fundus, you'll realize it's more pink, as compared to the cardia and antral glands, they are more mucinous. So let me show you, I think, some of the pictures. Again, this is just a low power picture of a histological picture of stomach. Again, this is the mucosa, here's the lumen, some muscularis mucosae, some submucosa, musculus propria. This is what we call the foveolar type epithelium. Histopathology of the stomach. I think the commonest one is the gastritis, but the less commons are the chemical gastritis, or what we call reactive gastropathy. As you can see from the term, the chemical gastropathy or gastritis mean that there has some kind of chemicals, especially like, let's say, bile acid, alcohol, NSAIDs, iron pill, and all that. So they can cause this kind of gastropathy or gastritis. Although it's gastritis, but you will not see much inflammation there, right? What you will see is the foveolar hyperplasia. There's going to be some lamina propria edema. There's going to be some smooth muscle hyperplasia. So like if you see, again, this is the epithelium. This is the lamina propria. You see these pink strands, kind of the spindly kind of strands of the smooth muscle. So this is what we can see. But what is striking in this picture that you will not see anywhere else is this, what we call sawtooth appearance, or corkscrew appearance. So just imagine this being the corkscrew. So whenever you see something like this is reactive gastropathy, and you will not see the inflammation. So this is the lamina propria. This is pretty clean lamina propria. It's not busy, it's pink, it's not blue. But when you look on the low power, even high power, the stomach overall, it's going to look very blue. So this is what we call the corkscrewing, and this is reactive gastropathy. The other day, one of my students, I don't know if he's here in the audience or not, but he told me he's going to UT Southwestern, and he just yelled that this is reactive gastropathy. They were very impressed from a student point of view that, it takes us a while to kind of understand these things. What do we mean by chronic active, chronic inactive, reactive gastropathy? So these are very subtle findings. And if you kind of understand this, if you have that eye, you can just pick that. Pathology is just pattern recognition. And once you recognize that pattern, you'll never forget. Moving on to the chronic gastritis, it's further divided into active and inactive gastritis. And what we mean by active in histology world is just if there's an activity, meaning if there are any neutrophils or not. So chronic active gastritis, again, is just means that if there's any neutrophils, and most of the times it's just caused by H. pylori. Whenever you have the Helicobacter gastritis, of course, it's a secondary to the infection from H. pylori, you will see abundant what we call the lymphoplasmacytic chronic inflammatory infiltrate into the lamina propria. The lamina propria will be all blue. There can be some lymphoid aggregates, but this is also normally you can see some lymphoid aggregates. But basically, you'll see a lot of neutrophils. So here, as you can see, this is one of the sections of the biopsy from the stomach. As if you, again, go back to the previous reactive gastropathy picture, you saw this, the lamina propria is just pink. There's nothing, there are no cells. Versus in this one, the lamina propria is just filled with these cells. Most of the cells are plasma cells. The plasma cells, you'll see all these blue dots, but then you have this eccentric kind of cytoplasm around it. There's a little bit of cytoplasmic rim around the plasma cells, versus the lymphocytes is just going to be one blue, dark blue dots, kind of round dots. And then within these crypts or glands or whatever you call it, you have these neutrophils around it, right? So if you take these neutrophils out, this is just chronic inactive gastritis. When you have the neutrophils in, this is chronic active gastritis. No matter if it's chronic active or inactive, you must rule out H. pylori. So H. pylori, basically, with an experience, I think if it's there, it can be picked up by H&E. No problem. I think every day we see H. pylori in my practice, and I think pretty much every single student of mine, they have seen H. pylori on H&E and also on stain, like antibody stain for H. pylori. So, but if you do not see it on H&E stain, then you must do H. pylori antibody, which is shown in this picture. So basically, it's just stains. The H. pyloris are found in these kind of the surface or in these lumens of the crypts. These brown dots is how it will stain. These kind of brown curved dots are those H. pylori. So if you're not able to find it on H&E, definitely go do a stain, because this is very important, because it's a very treatable disease. So you must have to mention if there's H. pylori or if there's no H. pylori. Moving on to the duodenum. So again, it's just the most proximal part of small intestine, which extends from the pylorus to the duodenal flexure and consists of 4 parts. Basically, I'm sure you're aware that it helps in the digestion of food by adding the bile from the gallbladder and pancreatic enzymes. So, this is kind of the microscopic anatomy. You have this pancreas kind of around this, the first 3 parts. You have the first part, the second part, and then around here is the 4th part. So most of the diseases, most of the duodenitis is kind of affects this duodenal bulb, first part of the duodenum, especially the peptic duodenitis and those kind of things that affect the first part of the duodenum. Anatomy, or microscopic anatomy wise, again, it has the mucosa, the submucosa, muscularis propria, serosa. What you need to know is what is the type of mucosa. So we know now that esophagus is lined by simple stratified squamous epithelium. Coming down to the stomach, you have these columnar epithelium, but these are kind of crypts that goes inside the lamina propria, versus when you come to the small intestine, you'll have villi, right? You'll have these villi. I mean, there's some crypt compartment kind of at the base, but mostly when you see the biopsy, you'll see so superficial, you'll only see the villus compartment, and the villus will have the scattered goblet cells. You may have some endocrine cells also, but basically you're looking at the villus component with some scattered goblet cells. There's going to be some abundant mononuclear cells. So again, if you see those mononuclear cells or lymphocytes or plasma cells within the lamina propria of small bowel, this is normal. But when you see it within the stomach, that's gastritis. So you kind of also need to understand all these minute things. So here you can see these finger-like projections, what we call villi, right? And then right here, you have some intestinal glands or crypts. You have some mucosa, and within the submucosa of the duodenum, you will have these Brunner's gland. This is again very peculiar to duodenum that you usually do not see anywhere else, unless if there's like heterotopia or something, right? So basically, again, villus projections with some scattered goblet cells. Common histopathology of the duodenum. The most common one is the celiac disease. Now, every time I get a biopsy of a duodenum, every single time, they will have us rule out celiac disease. So what is celiac disease? Just malabsorption autoimmune disease against certain antigens. And then the histologic features are the presence of intraepithelial lymphocytes. Again, we're talking about the epithelium, not the lamina propria. Intraepithelial lymphocytes. And then depending on what is the class, what is the severity of the celiac disease, you may see, the attenuated villi or flattening of the villi. And there's maybe, depending on the severity, you may see some additional lymphocytes and plasma cells. So the celiac disease, basically in this country, what we use is the Marsh classification. So Marsh is the classification. According to this Marsh classification, I think this is an old picture. Now we need to see about at least 30 intraepithelial lymphocytes per 100 enterocytes. So basically, we're talking about when you're looking at those epithelium within the villi, again, this comes with experience that, even on low power, you would be able to pick up that is there any increase in intraepithelial lymphocytes? And of course, then to count it, you'll have to go on high power. And every time you don't have to really count it. Again, this comes with experience. You may not have to count every time. So, but until you get to that level, you definitely go on high power. You kind of found the atrophy is pretty obvious from even low power, right? Or the flattening of the villi. So let's say if there's no flattening of the villi, it's just like the villi, you have intact villus architecture, like you have these finger-like projections, but then you have the intraepithelial lymphocytes within these epithelium, and then you count it. This is going to be Marsh 1. Again, no flattening. The villi are intact, right? But there's just increase in intraepithelial lymphocytes. This is going to be Marsh 1. Marsh 2 is kind of in between. And then in Marsh 3, there's like 3A, B, and C, where again, A is going to be partial villus atrophy, and then 3C is going to be total villus atrophy, meaning there's going to be, you will not see any finger-like projections anymore. This is going to be just flat epithelium, and you'll have tons of lymphocytes within the epithelium. So as you can see here, this is just almost subtotal atrophy. There's no villi at all, right? This is just flat. So this is what we call the kind of atrophy, the total atrophy of the villus epithelium, but you can still see these scattered goblet cells, right? So we know that this is from small bowel. As you can see, the lamina propria is filled with inflammation. This is more than what we normally see. And even within the epithelium, you have tons of lymphocytes. So this is going to be Marsh class 3. The other common pathologies that affects the duodenum is going to be duodenitis, which of course is just the inflammation of the duodenum. And this can be caused mostly by H. pylori, but then there's some other features also, other causes also, the NSAIDs used and whatnot. In duodenitis, you may also see some villus blunting, but basically this is just congestion of lamina propria, and you see a lot of inflammation And there's more than intraepithelial lymphocytes. You'll have some acute and chronic inflammation within the lamina propria here. And then before moving on to the lower GI, the other thing I think it's not covered here is the peptic duodenitis. Again, it's pretty common. And then peptic duodenitis, what you'll see within the epithelium will be kind of changed. There's going to be gastric metaplasia. So you will see gastric type of epithelium within the small bowel, and there's going to be mixed inflammation, acute and chronic. So that's going to be the peptic duodenitis. So I think we are on target. In last about 25 minutes, I'll try to cover the lower GI. And lower GI, again, this is an expensive topic, extensive topic, and then there's no way we can cover all lower GI. But what I've tried to do here is just to cover the most common polyps that we see again in general practice. You'll see there are all different types of polyps, but what I focused on today's presentation is just to kind of cover the basic that you will see in everyday life, that wherever you go for a rotation and whatnot, you will be looking at these things. So basically, polyp is just an exophytic sessile lesion that is distinct from the original mucosa, and it may be neoplastic, it may not be non-neoplastic, right? So essential features, just there's some anatomic change in the colon and characterized by kind of the outpouching. So colorectal polyps incidence increases with the age, and they're most common in Western countries as compared to the East. Although every polyp is not pre-malignant, but more about 95% of the colorectal adenocarcinoma, they arise from the polyps. So this is why, we have to make sure if there's any dysplasia or not in any of those polyps, but usually they are asymptomatic. So today I'll just cover these 4 most common polyps that I see in my everyday practice. It's going to be hyperplastic polyps, sessile serrated, traditional, and adenomatous polyps. So moving on to the hyperplastic polyp, this is again very common type of polyp, but mostly this is seen on the left side of the colon. So rectum, sigmoid colon, descending colon. This is going to be where you're going to see most commonly the hyperplastic polyp. And they can be numerous, but again, particularly within the rectum, and usually they are kind of small, less than 5 millimeter or something like that. There is no, again, this is very important, there's no risk of malignant potential or progression in a hyperplastic polyp. Completely benign, it's taken out and done. But they can occur throughout the colon, but again, most commonly on the left side as compared to the right side. There's going to be, I'll show you in the picture, there's going to be serrated architecture, what we call the sawtooth appearance that you also saw in reactive gastropathy, remember? But again, just remember in pathology, if you see sawtooth appearance in stomach, it doesn't mean that this is going to be hyperplastic polyp. So you got to know where this histological finding is. So in large bowel, and when you're looking at the polyp and you see this sawtooth kind of or hyperplastic or serrated appearance, you're thinking about hyperplastic polyp or you're thinking about sessile serrated polyp, okay? And so basically, these are very common lesions, and this is the most common type of serrated colorectal polyp. 80% of the serrated polyp. So serrated polyp can be sessile serrated polyp, traditional serrated polyp, or hyperplastic polyp. What is the most common? Whenever you see those sawtooth serration or hyperplastic change, you would first think of hyperplastic polyp, and then you look around and where is it from? And if you see some minute changes, and this is then you kind of go around if it's traditional serrated or if it's sessile serrated polyp. Again, at this stage, I think it may be too confusing. What is traditional, what is serrated, and then this, of course, will only come when you look at it every day. So, but at this time, you should understand the basic concept of what are the types of polyp and what are the features of those polyps histologically, right? So this has been discussed, that this can be seen in anywhere. And then again, the lifestyle for any kind of, polyp is basically low on dietary fibers, increased alcohol consumption, cigarette smoking, and all that. Those will put the people with increased risk of hyperplastic polyp development. Treatment is, of course, just the endoscopic biopsy or removal, and then this also confirms the diagnosis. So grossly, it's just like very small mucosal lesion, typically, like we said, is less than 5 millimeter. And it just appears like slightly elevated pill lesions at the colonoscopy. Microscopically, again, like I said, this is going to be serrated sawtooth appearance. And there's going to be, sometimes there is mild nuclear enlargement. So like, let's see, this is what we are talking about, sawtooth appearance or serrated, you see normally colon will have these crypts lined by goblet cells, right? When you have this dipping down and then this kind of branch here, like you see on the within the crypts, the crypts are kind of dilating and branching. And if you cut it like transversely, right? If you cut it like this, the sections can be cut transverse or just longitudinally. So longitudinally or transversely. So if you just imagine that if it's cut like this, you'll see the serrations kind of going on the left and right. But now if you cut transversely, this is going to be like round, and then you'll see the star shape. So you just have to pay attention, kind of that these are the same crypts. It's just they're cut in different planes of section, right? So biopsy is not like just a straight like this. This is just like a small biopsy. It can be kind of some of the areas will be longitudinal, transverse, and all that. So when it's cut, you're going to be seeing all these different kind of structures. So this is the serration branching going out, and when it's cut transversely, you're going to see somewhat like star shaped, like you see here. There's these different variants. You don't have to worry about the microvesicular variant, but what you need to know is this sawtooth appearance. Or these terms can be used differently. Like some people will call it sawtooth appearance, some people will call it serration, some people will call it just hyperplastic change, a star shape. Everything is just the same, but just understand this whole concept. And then some goblet cell variant where you see just a lot of goblet cell, but still again here it's branching. But because it's goblet cell, the branches you may not be able to see clearly. The other thing, when hyperplastic polyp, these branches or serration is going to be within the upper third of the crypt. This is very important feature that will differentiate them from what we call the sessile serrated polyp, which we're going to see later on. Moving on to the adenoma. Adenomas are definitely pre-malignant conditions, right? These are the pre-malignant neoplasm, and this will have some kind of dysplastic colorectal epithelium, right? Sometimes if it is referred to as just the conventional tubular adenoma, but they should be distinguished from the other serrated lesions. So by definition, adenoma will have at least low-grade dysplasia, right? So when we call something adenoma or tubular adenoma is the same thing. And in general practice, we just call it tubular adenoma. Again, one of the very, very common polyp. I mean, some days my students have seen like all day long, we are just looking at tubular adenomas. So this is very common that you will see. Again, pre-malignant lesion, and then the subtypes, they can be just tubular adenoma, villous adenoma, tubulovillous adenoma, or advanced. There's a lot of molecular changes involved, and then so we're not going to get into that much of detail, but just understand there are multiple different pathways. Because this is a pre-malignant condition, right? So there's an adenoma carcinoma sequence, and those genetic changes that occur before the polyp is actually identified. The most common one is the APC gene, but there are some other genes also which you guys are welcome to look at later on. Again, I just put this student put this picture also in just to kind of let you understand how this adenoma carcinoma sequence works. But at this time, again, this is going to be too detailed. So my point here is just to kind of let you guys understand the basic histology. And then perhaps at another talk, we can cover more of the molecular and genetics of those. So basically, again, the etiology is kind of the same for all the polyps, red meat, alcohol, increased body fat and all that. And if you have more dietary fiber, dairy products, more physical activity, this will put you at lower risk. Again, usually asymptomatic, and it takes anywhere from 5 to 20 years for a pre-malignant polyp to develop into a carcinoma. How they are detected, of course, in this country where the surveillance colonoscopy is mandatory. So this is how I think vast majority of polyps are detected. It can be pedunculated, it can be sessile, but basically prognostic factors of those adenoma, the risk which are associated with is that if you have higher number of lesions, definitely it has worse prognosis. Size of the lesion, if you have more villous architecture as compared to just the tubular architecture, and then the extent of high-grade dysplasia. That's why we always would like to rule out some high-grade dysplasia in the tubular adenoma. So just some gross pictures. You can have the pedunculated polyp, you can have sessile, which means doesn't have a stalk. It can be in pencolonic. It can be really anywhere in the colon. So tubular adenomas, you'll have the crypt architecture is still kind of conserved, but it may have some variable elongation. There's going to be increased number of glands. And by definition, again, the tubular adenoma will have at least low-grade dysplasia. And by that, we mean there's going to be hyperchromatic nuclei. There's going to be some nuclear kind of spindling or stratification, loss of polarity. Those are the features that you're going to, anywhere you go for dysplasia, these are the features. You'll have hyperchromasia, you'll have loss of polarity, you'll have some stratification, spindling and all that. And then there's going to be some decreased number of goblet cells and absorptive cells as we go on. Less than 25% kind of villus component is acceptable for tubular adenomas, but basically by definition, if you have about 20 to 75% of villus, then it's kind of tubulovillus. If you have most of the component in a polyp is villus, meaning greater than 75%, if that's villus, then it is called a villus adenoma. And advanced adenoma mean that there's a big polyp, like if it's greater than 10 millimeter polyp, and if it has more tubulovillus or more villus architecture, and with or without high grade dysplasia. So that's where we call this is an advanced adenoma. The differential diagnosis, of course, there's other type of polyp, which is the traditional serrated adenoma, even sometimes reactive chronic mucosa. Like it's not uncommon. I think we do come across every time that this is just reactive chronic mucosa. It's kind of looking like a polyp. There's a lymphoid aggregate and there's some inflammation. So remember the atypia, we're talking about atypia can be reactive, atypia can be dysplastic, right? When we're talking about the reactive atypia, it means the atypia is caused by the inflammation only. So we kind of have to look into that also. So, and the third is, of course, invasive carcinoma. Many times we get the biopsy, the surgeon or the clinician, they are sending it as a mass, and all we are looking at just superficial fragments of tubular adenoma. So which means that the biopsy is not deep enough for us to have the adequate sampling. And all we see, because again, remember, most of these carcinoma are coming out from the adenomas, right? So many times you still have that adenoma around it, and then the biopsy is not representative. And although the clinical picture is all carcinoma, but we, as a pathologist, we can only call what we see. So if we don't see a carcinoma, we just can give a diagnosis of carcinoma. And in those cases, we put in a comment that all we see is just superficial fragments of tubular adenoma. And although the mass may represent an adenocarcinoma, but the sample that we are looking at just represents the tubular adenoma. So it means that for confirmation, and many times they may just treat clinically. It looks like a malignant tumor. They can go ahead and treat. But as a pathologist, again, you cannot give a diagnosis of something that you don't see on the slide, right? So just we have to be careful with that. So again, this is what we are talking about. This is low-grade dysplasia, tubular adenoma. You see, and I tell my students most of the time that this is a low-power diagnosis, meaning when you're looking under the scope, you look at the normal colon, you will never see the normal colon to be like this blue, right? So this is too blue of a colon, right? This just look at these, the hyperchromatic nuclei, right? The stratification that we talk about. Now, when you compare this to the normal colon, when you look at those at the cellular levels, you will see that this is very dark as compared to the normal colon. You'll just have this one single line of epithelium, versus in here, you can clearly see there these stratified. The nuclei are not polar anymore, that the nuclei are coming all the way to the top, right? The nuclei coming all the way. And when you go in a higher power, you'll also see some mitosis and all that. So basically, again, when you see this like too blue, is this tubular adenoma. And whenever you have a tubular adenoma, especially when the size is greater and when there is more villus component, you always rule out the high-grade dysplasia. And what we are talking about high-grade dysplasia, as you can see here, you see what we call cribriforming or complex glands, like the glands are back to back now. If you go back, you see the glands are still kind of separate. You have one gland here, one gland here, and all these glands, although they are atypical, but they're not crowding, they're not cribriforming, they're not coming out to be together. You see how they are fused here? This is the architecturally what we call the high-grade dysplasia. And then there's completely loss of mucin. There's no apical mucin, excuse me, and then there's marked pleomorphism also. But this pleomorphism you can only see on high power. Again, pay attention, many times I've seen my students, because they just know that this is low-grade dysplasia or high-grade dysplasia, and because when I'm talking, they'll just go ahead and describe the features that you can never see on low power. For example, mitosis, you cannot see on low power. So just be careful when you speak up. You know what you're talking about. Like, do not say it before you look at it on the high power. You know what I mean? So this is what we're looking at, high-grade dysplasia. Moving on, and this clearly on low power, you can see that this is different. You have all these villus-like projection, finger-like projection, as if this was small bowel, right? But this is again too blue, and this is very hyperchromatic. There are no goblet cells here. And when you go on high power, you see all of these cells are very dysplastic. They are stratified. This is not a single layer of nuclei anymore. They're very stratified. You see they are going all the way to the apex, and you also have these mitotic activity. And again, remember that when you have this more than 75% of the component in the polyp is, if it's villus, then you call it villus adenoma. And when you have mix of villus and tubular, you'll call it a tubulovillus adenoma. But in this case, but again, when you have villus adenoma, always rule out for the high-grade dysplasia. And moving on to the traditional serrated adenomas or polyps, they are not very common ones. I mean, but again, just something that you should know of. Again, this is going to be serrated neoplastic precursor lesion, and usually they are associated with BRAF mutation, and they are MSI stable type of polyps. They will be characterized by prominent eosinophilic cytoplasm. When we're talking about eosinophilic, think pink, right? So pink, more pink is what we mean eosinophilic. They will have more like tubulovillus kind of filiform architecture. Then there's going to be some ectopic crypts also, and then they are most oftenly found in the rectosigmoid. There is some slight male predominance, but no racial predominance. The average age is diagnosis kind of older, 7 decade of life. Again, these are also usually asymptomatic, and when they become bigger, of course, that's where they might be associated with some symptoms also. Routine surveillance is all it is indicated, and they may arise from what we call microvesicular hyperplastic polyp also. Again, you don't have to know about it at this age. Let's see, microscopically, again, they're going to be protuberant white villiform growth patterns with there's maybe some slit-like serrations in there. Pseudostratified epithelium, again, very pink, eosinophilic, and I think you'll understand more when you see the picture. Like here, you see this polyp is looking different than, excuse me, what we call tubular adenoma. As you can see at the surface, there is kind of a stratification, some loss of polarity, but what is striking here, you see all the surface. Number one is it's very villus-like, filiform-like, but then what you see at the cellular level, this is very pink, you see, very eosinophilic. And these also have some serrations. You see these star shape that we saw previously in the hyperplastic polyp. You will also see the same kind of serrations in the traditional serrated polyp. But the difference here is that number one is looking more villus. You have these fibrovascular cores, right? But the surface, when you look at it, this is very pink, very eosinophilic. So these are what we call the traditional serrated polyp. Again, you see these serrations branching, and when you go transversely, you will have these kind of star-shaped lumen. So that's, and then lastly, I'll just go about the sessile serrated adenomas. And this is again a neoplastic precursor lesion. So hyperplastic, benign. Sessile serrated, traditional serrated, tubular adenoma, all of those are premalignant, and this can the sessile serrated polyp and the tubular adenomas have a different genetic pathways, just to so that you're aware of. So, but the criteria for polyposis syndrome, so serrated polyposis syndrome, is that you need to have at least 5 serrated polyps proximal to the sigmoid colon, and with at least 2 greater than 1 centimeter of size. Again, I mean, you don't have to remember all this, but just kind of giving an idea what we mean by polyposis syndrome versus you just have a singular polyp or multiple polyps, and when to call it a polyposis syndrome and all that. Mostly the serrated polyp are proximal to the sigmoid colon. So basically, if you remember that the serrated polyp are seen on the right side, ascending colon, cecum and all that, while the hyperplastic polyp are mostly on the left side of the colon. They are again neoplastic, pre-malignant lesions of the colorectum, and if they are present, the patient would need to go increase surveillance among the colonoscopy, right? And then they may develop some traditional cytologic dysplasia, and they may also progress to colorectal carcinoma with microsatellite instability. So this is basically what we are talking about in a sessile serrated polyp. Again, you see these serrations, you see these branching. In this sessile serrated polyp, the branching are going to go all the way through the entire length of the crypts, right? They're going to go all the way towards the base also. The base will be more dilated, and the buzzword here is boot-shaped, right? So when you hear that, the serrations are all the way through to the base, and then the base is more like you see here, this is the leg coming down, and this is becoming the boot here. So when you hear this is the buzzword for sessile serrated polyp. When you hear the boot, or like even one horizontal gland kind of towards the base, this is sessile serrated polyp. And this again, the surveillance is going to be increased surveillance in there, and these are sometimes associated with BRAF mutation, but negative for KRAS mutation. And they're always, as the definition in this says, they're always sessile. They are somewhat broad and proximal distribution, like they are mostly towards the cecum and ascending colon. And let's just mention again the same thing that you have these sawtooth serrations, and this one you may have some abundant mucin as compared to the tubular adenomas. But basically, again, the bottom line is that the basal crypt dilation here, the base of the crypt will be dilated or will become more boot-shaped. Now, by definition, sessile serrated polyp are not dysplastic. So if you see here again on low power, how this is becoming more blue here. So it means that now they have some low-grade dysplasia, and not at least high-grade. In this power, it doesn't look like high-grade dysplasia, but when we go on high power, you can see some high-grade dysplasia also. So this is what sessile, and I think this should be it for, I have some, maybe one more slide, and this is just a prognostic factor. I think approximately says that 15% of patients will develop adenomatous polyp, meaning it may have some high-grade dysplasia and eventually a colorectal carcinoma. And as we discussed previously, the greater size will have greater risk, greater number of polyps will have a greater risk. And then treatment is just polypectomy, or sometimes they even do, if this is a bigger polyp, they may do just endoscopic mucosal resections. And of course, the recommendation is to completely remove all the polyps, and lesions greater than 1 centimeter with high-grade dysplasia should be managed clinically like a high-risk adenoma. And this is all I have for you guys. And we'll move on to the questions if there's any.
Thank you so much for your mentorship and teaching, Dr. Khurram. We will now begin our Q&A session. We've compiled a couple of questions, and now we're ready. So to start off our Q&A, are there any subspecialties in pathology that may allow pathologists to have more one-on-one or face-to-face interaction with patients?
So basically, yeah, this is, I think, pretty common. You need to understand, as a pathologist, there's not going to be too much of patient interaction. So if this is something that you became a doctor just to interact with patients, so this may not be the field for you. But there's always patient encounters, of course. For example, if you are doing heme path, there's definitely some patient encounters. You can do bone marrow biopsies. There are some, I mean, again, this is not common, especially because this is all based on the reimbursement, and all the procedures will have more kind of revenue. So this goes to mostly clinicians, and then how the practice model is. So most of the times those procedures may not be done by pathologists, but still there are many practices, many groups that the pathologists will do bone marrow biopsies. But that's kind of the encounter that you may have. The other thing is cytology. If you're a cytopathologist, then you do a lot of FNAs. Again, this all depends. It is becoming less and less again, because of how the reimbursement model is, and then but it is there. So those two are where you can have some patient encounter. Then again, derm path is different. So many times the derm pathology fellowship is done by the dermatologist actually as compared to the pathologist. So if you are a derm path person, then again you may have a lot of patient encounter, and then some of my friends I know, they are derm path. They went through pathology, then derm path fellowships, and they are even doing some additional fellowship, and they're even doing some surgeries and more surgeries and all that, and the biopsies. Or so those are a couple of specialties that you would have some patient encounter.
Thank you, Dr. Khurram. That was very helpful and interested.
Yeah.
I know that we've had a derm path specialty in the past, so that was very interesting.
Right.
And then we can always refer back to that YouTube on our channel. So our next question comes from Pilar Lopez, and he asks, how many samples do you require for esophagus, or or different types of samples that you may need?
Actually, I mean, to be very honest, just one good sample is enough, right? I mean, if we get like, I mean, I don't know, one even less than a centimeter, like centimeter is pretty big if you look at the under the microscope, right? So just one very good, again, the point is not the quantity, it's about the quality. What we are talking in histology is just the quality. So if I have, like, let's say 1 3 millimeter um, tissue on a slide, and that has an invasive carcinoma, can I not call it? I have to call it, right? I mean, so it's just one, but it's just is the representative of the lesion. Many times, on average, I mean, I think on average, whenever they go, they just do a bunch of biopsies. For example, when they are going for a pediatric biopsy, they try to do just once they are in, because I mean, it's going to be hard to go again if you get non-diagnostic. So, for example, when they're doing pediatric biopsies, they try to just get the biopsy from all over. So they'll do some proximal esophageal biopsies, then they do the mid esophagus, and then they do the distal esophagus. Then they'll get some couple from the stomach, duodenum, and similarly from the colon. But when they're going in adults, and then if they don't colonoscopically or grossly see much, then they'll just do some random biopsy. So there's not like a particular number again, but actually the representative from the lesion, right? So, for example, if they want to rule out GERD, or they want to rule out Barrett's esophagus. Again, if you pay attention to Barrett's esophagus, we can only call it when we have the GE junction biopsy, meaning when I'll have a gastric part also. When I have the columnar mucosa, only then I can rule out if there's any intestinal metaplasia or not. Now, if I only get the squamous mucosa, then I can't comment, and I can't call it Barrett's, or I can call it intestinal metaplasia, right? So it's important that where the biopsy is from and how much is this of representative as compared to the number of how many biopsies we have.
Thank you, Dr. Khurram. That was very helpful. I know that I think a common misconception is that we need 3 samples. So I get it. So it's one good sample depending on the biopsy.
Correct.
Thank you. Another question came up about H. pylori. As Huda Huck asks, what stains do you use for H. pylori?
So H. pylori, basically, I think in olden days, I think when I was in my residency, I remember that every gastric biopsy, they used to do a Giemsa stain. So it is not an H. pylori, it's just a special stain, which kind of also picks up H. pylori, will make it H. pylori more prominent. So there was the Giemsa stain. Then I think some practices, they do another type of stain, a special stain, but basically the gold standard is the actual H. pylori stain. We're talking about the antibodies. So there are 2 types of stain pathology, right? There are some special stains which does not have the antibody. So, for example, silver stain, you have reticulum, you have iron stain. All those are just special stain. Then you have the immunohistochemical stain, which means that they are bound to a specific antibody, right? So, for example, when we are trying to identify a specific lineage for a cancer, we will do some antibodies. For example, when I want to rule out if this is a squamous cell carcinoma, then I will do an antibody against squamous cells. So for example, P40, CK5, those are the antibodies that will kind of highlight the squamous cells, right? Then there are some antibodies that will highlight the adenocarcinoma, for example, in lung TTF1. So basically, those antibodies are kind of directed towards a specific antigen. So the gold standard for H. pylori is the H. pylori stain, H. pylori antibody.
Got it. Thank you very much, Dr. Khurram. I appreciate it. And there's one follow-up question that came up just now. So where exactly do you look in the H. pylori slide? And are there any specific locations for the adherence for the stain?
Yes, yeah, and I think it was in one of my slide also. So basically, you look kind of at the surface, towards the surface of the crypt. You know, when you're looking at, I can explain it more on the slide, but I think it was there when, if you go back onto that slide, you will be easily able to identify. You kind of look at the surface of the crypt, and sometimes you can also see within the lumen of the crypts also.
Thank you, Dr. Khurram. Now we'll be asking you questions based on your career path and specialty. A couple of pre-med students are very interested in learning about why you chose to pursue the pathology specialty.
Why? Very good question. And to be very, very honest, I just chose it because of the lifestyle. And I think many of my students, they already know that I did internal medicine before, pathology. So I did completed my internal medicine residency from Pakistan, and then I came to this country. I got a job in a lab, and to be very honest, I was only fascinated by the lifestyle of a pathologist, and I'm like, man, this is cool. I kind of would like to do that. And of course, you need to have the passion now, but you need to like that. You need to love that. In fact, not just like. And so, but my initial kind of thing was just because of the lifestyle. I mean, it's pretty chill. I'm sure all of my students, and I get to do all these things that I'm doing, like I'm mentoring into all these different capacities and through different platforms, is only because I have the time to play around with all these, and I'm passionate about that also, and this I can only do because of my current lifestyle. Again, I cannot brag about it, but just to be honest, some of the practices, you go in at 8:30, 9-ish, and then you're kind of done by 4. It's literally 8 to 4 kind of a job. And some, of course, if you are in a busier model, in a what like an RUV or in a production model, or if you're like a partner at a very busy practice, then of course your day can be busier. But on average, it is kind of 9 to 5. Then again, majority of times, again, see, most of the practices, most of the hospitals are community based, right? So that means that the calls are going to be very less. What kind of calls do we get? If we are called about a frozen section. So when do we get to the hospital? If we are called about a frozen section, and when do we do the frozen sections? Frozen sections are usually done when there is a transplant, when there is a malignancy, and they want to rule out if the margins are positive or negative. But other than transplant, those malignancies, and most of those are scheduled, those are elective surgeries, right? So those are not emergency surgeries. So for those emergency surgeries, really, we don't need to go in there and tell them what it is. Other than, for example, there's a leukemia slide or something like that. So those are the rare emergencies. And then again, with those community practices, you may not get those complicated cases, especially if you are, for example, if I'm in Houston, and most of the those complicated cases will end up going at a bigger cancer centers, right? So the point is that in those community kind of settings, you may not be even called when you're on call. Your weekends are completely free. You don't have to do anything on the weekends. So it's a pretty good lifestyle, and I think one of the best. When there was just like before this talk, one of my friends shared a survey in another physician group, and I just trying to find that out. Yeah, it's done by Medscape. It's published in Medscape somewhere. It's 29 specialties ranked by happiness. So number one, there is orthopedics. Surprisingly, orthopedics is like 65% happy. I'm just reading it from that article now. ENT are 65% happy. Then you have ophthalmology, dermatology are 62% happy, and pathology is again number 3, 62% happy. This is just based on happiness. Like again, I tell my colleagues and friends also that I believe, I mean, nothing against, of course, any specialty, but this is just my personal feeling. I believe that now that I know what internal medicine is like, And I've done that too. And I feel that I would have never been happy doing, for example, continuing doing what I thought I was born to do. But later on, I, kind of found out my passion about pathology. So just something there.
Thank you, Dr. Khurram. That was very helpful. And yes, I've also heard about that study that pathologists tend to be much happier. And there's just this stereotype that pathologists are super happy, very open to mentoring students, and very welcoming during rotations. And as a follow-up, what is your day-to-day schedule at work like? Because you're also a clinical assistant professor, you're also working as a staff pathologist. So what is your day-to-day?
So day to day again is my primary job is with, let's say, for example, no, so that's my primary job. The other is again clinical, and then for teaching and all that. It's just like depends on the number of student I get, and again the students that I get. The teaching for pathology is different. So I think back in medical school, I think how we learned is that pathologists will come and give us a lecture, and that was about it, right? But the actual teaching of pathology is different. And then I believe in one-to-one sign out. So whenever my students are there, so whatever cases I'm looking at, so my cases are my slides, right? So patient came in with diarrhea and whatnot, and they did a GI biopsy, and this is what I'm looking at. So my students is with me right there. Then I'm just teaching it one-to-one. This is what I'm looking at, and this is what I mean by tubular adenoma. These are the changes, and we literally point it out on the scope that this is exactly what we mean by this. So this is kind of the teaching side. And the day-to-day, again, most of practices, they may have their own schedule. Like, so where I work, we have a schedule where I'll be on call for one day, which means that I'll be taking any calls, any frozen sections, any transfusions calls, any clinical calls. So I'll be taking those ones. And then next day, for example, I'll be on FNA service. So I'll be going on for the on-site evaluation. So this is another thing that where you can have patient encounters when you go on-site. Some practices, again, are very busy for on-site evaluation, which we call ROSE, Rapid On-Site Evaluation. And then where we just go in, again, the clinician or someone will be poking in the needle, giving at the sample. We will put the sample on the slide and we'll tell them what we see, if it is diagnostic, if it's non-diagnostic, if it's adequate, if it's inadequate. So this is kind of, and then for example, day third, I'll be just looking at the slides. And all these 3 days, I'll be looking at the slides, but my primary responsibilities would be to go on for procedures, to go on for frozens, to take any calls. At the same time, when I'm in my office, I'll be looking at my slides. So again, basically, we are looking at 8 to 4, 8 to 5 kind of a schedule on an average day. I think.
Got it. Yes, I was muted. Sorry. Got it.
Right,
Thank you very much, Dr. Khurram, also for reminding me I was muted. So some students are also interested in possibly pursuing research opportunities in pathology to figure out if it's the right field for them to pursue. So can you tell us a little bit more about if you have any research opportunities that you think that students should possibly pursue, any recommendations for what else students should be doing to decide if pathology is the right fit for them?
Yeah, I mean, there are tons of research opportunities. Again, if you want to decide if this is the specialty that you want to go, I would advise research would not be the way to go about it. I mean, deciding if you want to be a pathologist, research is not, unless if you want to go in completely research industry and all that, that's a different story. For a general, any kind of subspecialty pathologist, research is always important. Again, it also depends. I've done a lot of research when I was in my residency and in my fellowship and all that, but that was about it. Some people are passionate about it. So if you want to do research, you will kind of have to go to more academic practice as compared to the community practice, right? In the community hospitals, really we care about is you have a certain volume, you have certain workload that you have to finish, sign out, and that too on a timely manner, right? Because remember, the patient is waiting for the biopsy result. The attending the entire clinical, you're kind of at the center where everything kind of, once the patient has a biopsy of anything, everything kind of rotates around and everyone is waiting for your biopsy. So it's very important that, we have to keep that under certain time frame that, many institutions will have a turnaround time for a biopsy, 48 hours, for example. In 2 days, we have to give out the result, right? So in most of those practice is focused on signing out a case as compared to the research, but there's tons of research opportunities. So you can always start finding those faculties. It's pretty much, I mean, these days, I mean, you just learn how to do research. Everything is available online. You kind of figure your way around, and then you kind of read more articles and kind of see. But on a day-to-day practice of a pathologist, research, I would say, is not that important. Now, when you are applying for the residency and you want to aim for like big academic settings and all that, definitely in your CV, it definitely would adds up whatever kind of research you have. But again, the decision of becoming a pathologist, I think, will not be based on research, I believe.
Thank you, Dr. Khurram. That was also very helpful to understand the differentiation between, I guess, academic centers and also community practices, and where, research is much more enunciated and appreciated more on the academic side. So we really appreciate you taking the time to mentor us today. I understand that it's also Eid, which is our one of our two major holidays in our religion of Islam. So I wanted to wish you Eid Mubarak on TeleShadowing's behalf. We really appreciate you taking the time to mentor us, especially during the holiday. It's celebrated by Muslims globally, and it marks the end of our Ramadan. So we really appreciate it, and thank you for celebrating with us as well and learning.
Sure. Thank you very much. It was pleasure. It was such a pleasure, and Eid Mubarak to everyone. And I think again, this is going to be on YouTube also. The next lecture, I must say, is going to be very interesting, and I would be very much interested in attending also from one of my colleagues, Dr. Sadaf Mehman. She's going to be talking about digital pathology next week, I believe. So I would encourage everyone to attend that lecture too, to kind of complete this 1 month pathology elective through TeleShadowing.
Yes, that was actually also on our next slide with our closing session and future session dates. So our next set, so we also have our quiz for the session available now. So it's live now. The link to the quiz will be sent in the chat box. It's also on teleshadowing.com/certification in case you missed the link. It's also on our website. And for our future session dates, we'll have Saturday, April 29th at 12 p.m. Eastern Standard Time in digital pathology with Dr. Sadaf Mehman. And we'll also have our next month, which is going to be our public health and pediatrics month. So that concludes this week's shadowing. These days will also be posted throughout our social media outlets, so please be sure to follow us at TeleShadowing. We really appreciate you attending today's session and also conducting it, and we hope to see you in upcoming sessions soon. And this concludes this week's shadowing. Thank you.
Thank you. Have a good day. Bye.